Hello guys, how are you? Hope you are doing well. Welcome to our fifth lecture of Last Minute Pharma, your exam antidote. Okay, today we are in a series. we were in the series of general pharmacology, and this is your fifth lecture where we will be discussing about furthermore about metabolism. That is factors which are going to affect the metabolism. Okay, this topic which is there. Okay, it's very interesting and very important. Okay, now if you have not understood the metabolism concept properly, please go back and you can refer out what is metabolism. Okay, see, metabolism in short, if I explain, it is nothing but a small, or nothing but a chemical alteration. It's nothing but a chemical alteration of a drug. Now the main thing over here is, why do we need chemical alteration? You have to go back to the last video and I have explained in a very detailed way. Okay, so without wasting much time, let us try to understand what are the major factors which are going to affect the metabolism over here. Okay, now you have to understand, before understanding the factors, okay, make one thing in very clear in your mind. Okay, that is, whatever the factors are there which are going to affect metabolism, no, they are nothing but the factors which are going to affect the liver function. Okay, simple, no? The factors which are going to affect the metabolism is nothing but the factors which are going to affect the liver function. Okay, now let us try to understand about the major factors. That is one of the age. Okay, excuse me. So mainly over here we are classifying into three ages, that is neonates, adults and elderly patient. Now mainly if we talk about the neonates or the newborns, okay, what is the problem with this? That the liver which is there in the neonates, it is not developed. Okay, the liver which is there, it is not developed, and because it is not developed, the enzymes which are there will not be secreted. So if enzymes are not secreted, then what will happen? Obviously the metabolism which will be there is comparatively slow. One very important thing you have to remember, the metabolism which is happening in the neonates and in the elderly patient is comparatively in a lesser extent compared to the adults. Okay, I hope it is clear. The rate of metabolism in the neonates and elderly patient, it is slightly less compared to adults. Now why that is so? In neonates, because the liver that is there or the organs which are there, it is not developed. It is not developed. That's why the metabolism is slow. Now one of the very famous example which is over there, that is chloramphenicol. Okay, chloramphenicol, which is a drug. When you give this chloramphenicol in the neonates, when you are going to give this chloramphenicol in the neonates, instead of getting, it won't get metabolized. Okay, instead of getting metabolized, this is going to start to form conjugates. This will start to form conjugates, and the conjugation of this chloramphenicol will lead to a very major drug toxicity in the neonates. And this drug toxicity which is there, it's a syndrome which is called as gray baby syndrome. This is called as the gray baby syndrome. This is called as the gray baby syndrome. What is gray baby syndrome? It is nothing but it's a drug toxicity which is caused due to chloramphenicol in the neonates. Okay, some grayish patches will be there in the on the baby's skin. I hope it is clear. So did you understand? Because the metabolism is slow, the drug will start developing. Okay, the drug will start developing in the systemic circulation, and that will lead to the toxicity. And one of the major example is your gray baby syndrome. Similarly, now what is the problem with the elderly patient? Elderly patients which is there, if we talk about the liver of the elderly patient, one major thing is that there are a lot of comorbidities. Okay, there are many of comorbidities, like different diseases or polypharmacy you talk about, or comorbidity you talk about. It's one of the major factor. Okay, so in elderly patient, as the patient crosses 45-50, the liver starts to get damaged. The hepatic cells which are there starts to die. So what will happen? The hepatic hepatic problems will be there. No, so because of that, the secretion of enzymes will not be there. So because secretion of enzyme is not there, again the metabolism will not happen, and this metabolism doesn't happen, it will lead to the toxicity. That's why it is very important, whenever you are giving a drug to a neonate or an elderly patient, you have to monitor the toxicity parameters, because these are very important, because they are more susceptible. The neonates and elderly patients are more susceptible to the drug toxicity. I hope it is clear. So one of the drugs which are there which will cause toxicity in the elderly patient, that is your lignocaine. That is your lignocaine, or even you can say your propranolol. Okay, you can say your propranolol, which is the antihypertensive drug, beta blocker. Okay, all these things we are still waiting. We are still waiting for ANS and cardiovascular system, where we'll be having amazing codes. Okay, for you guys. So stay tuned to the channel. Okay, because you're gonna get many more notes. You'll be getting codes. You'll be getting mnemonics. You'll be getting, making your pharmacology the easiest boost. Okay, fine. Now this is about the age factor. Now we are going to start about the diet. I hope age is clear. Now we'll discuss about the diet. Now diet which is there, see, diet plays a very important role, because if you want to keep your liver healthy, you have to have a proper diet. But if you're having an improper diet, like excessive alcohol drinking or smoking, or increasing the oxidative stress in your body, then what is going to happen? Obviously the liver is going to get damaged. Now when liver is getting damaged, obviously it will affect the metabolism. See, remember my words what I told you in the starting of the lecture, that whatever the factors which are affecting the metabolism is nothing but the factors which are going to affect the liver function. Okay, I hope it is clear. Diet is clear over here. There's nothing but if you're having an improper diet, the hepatic microsomal enzymes will not be produced, and if enzymes are not produced, then the activity will not be shown. Now next is your diseases. Like we saw, the elderly patients are going to have comorbidities. One of the very common comorbidity is your liver cirrhosis. Okay, what is liver cirrhosis? Liver cirrhosis is nothing but it is the death of the hepatic cells. Okay, it's nothing but the death of the hepatic cells. Now if hepatic cells are dying, then what is going to happen? Liver function is going to get reduced. Now when liver function reduced, enzymes will not produce, metabolism will be not there. So because of these, one of the very important example over here is that people who are having liver cirrhosis, okay, like the patients who are going to have liver cirrhosis, if you are going to give a drug, that is your diazepam, if you are going to give diazepam, because this drug, if you are having liver cirrhosis and the patient is taking diazepam, this will not get metabolized, and because it will not get metabolized, this diazepam will have a prolonged action. This diazepam in the patients having liver cirrhosis, if it is administered, then what is going to happen? The action of the drug is going to be prolonged. It's going to have a prolonged action. I hope it is clear till here. That is about the liver cirrhosis or diseases. Now we are going to discuss about the genetic factors. Okay, so whenever a genetics or a gene, okay, like it is affecting the drug, okay, drug activity, whenever a gene is going to affect a drug activity, that study which is there now, that is called as pharmacogenetics. That is called as pharmacogenetics. Okay, now one very famous example of like genetic alteration which is over here, that is one enzyme is there. Okay, please have a note. Okay, focus over here. There's an enzyme which is called as glucose 6-phosphate dehydrogenase. Okay, I'll just write it down. That is glucose 6-phosphate dehydrogenase. This enzyme which is there, okay, this enzyme is very much important for maintaining the RBC integrity. Okay, this enzyme which is there, it is very much important for maintaining, the RBC integrity. This is important for maintaining the RBC integrity. But what happens is, in the patients, note it down, in the patients who are going to have this deficiency, okay, there's nothing but G6PD deficiency, and we are administering the drugs, and we are going to administer the drugs like your sulfonamides, you can say, then you can say dapsone, or then you can say your primaquine. These drugs which are there, if you're administering to a patient who is going to have G6PD deficiency, then this is going to lead to the lysis of RBC, or this is going to lead to the hemolysis. So we should be very, it should be kept in mind that the patient who are going to have G6PD deficiency, okay, so what is going to happen in this deficiency patient, if you are giving these drugs like sulfonamides, dapsone, primaquine, that will lead to the hemolysis. This is one of the major factor which is going to affect the metabolism, that is called as pharmacogenetics or genetic factor. Now, last but not the least factor which we are going to discuss, and this is very important for your examination, and for, see, if you don't understand this topic, right, simultaneous administration of a drug, it's a very important topic, because in the further upcoming chapters, you have to understand this, okay? Whenever in examination you write pharmacokinetics, right, then this plays a very important role, okay? That is, when you are going to administer two drugs simultaneously, okay? When you are going to administer two drugs simultaneously, it might enhance the activity, or it might enhance the metabolism of the drug, or it can decrease the metabolism. So if the metabolism is enhanced, okay, that is called as induction. That is called as induction, okay? So it's an enzyme, right? So you can call this as your enzyme induction. This is called as your enzyme induction. And when you are administering the two drugs, when you are going to administer the two drugs, and the activity or the metabolism which is there, that is going to get decreased of a particular drug, that is called as enzyme inhibition. So now we are going to discuss in detail about what is enzyme induction and what is enzyme inhibition, and this is a very important topic for your examinations. Now we are going to discuss about the simultaneous administration, okay? As I told you, this is one of the major topic or important topic which you have to understand. That is, when you are going to administer two drugs, okay, two drugs when you are going to administer, then it might increase the metabolism of the drug, or it might decrease the metabolism of the drug, okay? Now try to understand. See, mainly your hepatic enzymes which are there, you are dividing it into two types. That is your microsomal enzymes and non-microsomal enzymes, and you are dividing this microsomal and non-microsomal based on where this enzyme in the hepatic cell is present. Either it is present in mitochondria, or small endoplasmic reticulum, or your cytoplasm. So based on that, you are dividing it into microsomal and non-microsomal. And then plus one more factor which is responsible is, like, microsomal enzyme is responsible for doing certain active, like certain type of reaction, like only reduction reaction, glucuronidation reaction, whereas similarly your non-microsomal enzyme, on that basis you are dividing it into two, that is microsomal and non-microsomal. I hope it is clear. Now what are these, like, what are these concept of enzyme induction and enzyme inhibitor? When you are administering a drug to a patient, okay, when this drug is going to activate the synthesis, it's going to activate the synthesis or secretion of the hepatic enzyme, that is called as the enzyme induction. You know what is induction, right? Induction means you're going. So what's going to happen over here? When you're going to give a drug to a patient, it is going to activate the metabolism. See, going to activate enzyme next, going to activate the metabolism. Now, obviously, there are some advantages. What is the clinical relevance? Okay, what is the clinical relevance of this enzyme induction? Mainly, it can be in positive aspect also, in negative aspect also. Okay. Now, for example, like example of the drugs which are going to induce the secretion of liver or induce the secretion of hepatic enzymes, it is your rifampicin, phenytoin, and carbamazepine. Okay. Now, one of the important reaction or important relation you have to understand is about rifampicin and oral contraceptives. Okay, you have to understand about the rifampicin. Excuse me. Yeah, rifampicin and your oral contraceptives. Now what is going to happen over here? This rifampicin which is there, it is going to induce the enzyme which is responsible for metabolizing the oral contraceptive. Isn't it interesting? Now what will happen over there? If the rifampicin has increased the metabolizing enzyme of your oral contraceptives, then what is going to happen? Oral contraceptives will get metabolized and excreted without showing any activity, and this will lead to the contraceptive failure. If you are administering rifampicin, this rifampicin will induce, this is going to induce the hepatic enzyme, this is going to induce the hepatic enzyme which is responsible for metabolizing the oral contraceptive, and once this oral contraceptive will get metabolized, then what will happen? If it metabolizes too quickly, then what will happen? Without showing its activity, that is contraception, without showing its contraception, this drug which is there will get wasted, you can say, or will get excreted. So this is one of the major negative part about your enzyme induction. Without showing the therapeutic outcome, okay, without showing the therapeutic outcome, it's going to get excreted. So these drugs which are there, that is rifampicin, phenytoin, and carbamazepine, these drugs are going to induce the activity of the hepatic enzyme. I hope it is clear. Now, but this has an advantage also about the microsomal induction, that is about your phenobarbital. Okay, in case of your phenobarbital. Now, one condition that is called as your you're having neonatal jaundice. Neonatal jaundice. So in these patients, okay, who are having this neonatal jaundice, if you are going to administer phenobarbital, note it down that phenobarbital which is there, okay, phenobarbital, I'm just writing short over here, PBT, that is phenobarbital. This phenobarbital which is there, what is this going to do? This is going to convert the unconjugated bilirubin. This is going to convert your unconjugated bilirubin to your conjugated bilirubin. Now, how is this related? You might be thinking, how is this related? Because the phenobarbital which is there, that is going to activate the enzyme that is called as glucuronide transferase. This is going to activate, I think you remember ROBC, right? ROBC, phase 1 reaction. So I'm sorry, phase 2 reaction over there, right? Now when you're over here, you have to understand over here is that this glucuronide transferase which is there, okay, this is responsible for converting your unconjugated, see, your neonatal jaundice which is there, that is mainly because of unconjugated bilirubin, okay? Then neonatal jaundice or jaundice which is there, it is because of unconjugated bilirubin. But if you give this phenobarbital, then what is going to happen? That your unconjugated bilirubin will get converted to your conjugated bilirubin. I hope it is clear till here. You're understanding what is your enzyme induction? Exactly opposite is your enzyme inhibition. Now what will happen in this? There are certain drugs which are going to inhibit the activity of the hepatic enzymes, okay? These drugs which are there, okay, like your chloramphenicol, ciprofloxacin, or erythromycin, these drugs which are there, they are going to inhibit the activity of the hepatic enzymes. Now, one of the very common, okay, very common this is seen, that is interaction or like when you're administering your warfarin and your chloramphenicol together, okay, when you're going to administer your warfarin and chloramphenicol together, then what is going to happen? Try to understand this chloramphenicol drug which is there, okay, this is going to inhibit, what is it going to inhibit? It's going to inhibit the hepatic enzyme which is responsible for metabolizing your warfarin, okay? This is going to inhibit the enzyme which is responsible for metabolizing of warfarin. So then what will happen? If the warfarin which is there does not get metabolized, then what is going to happen? This will lead to the very basic concept. This will lead to the drug toxicity. And the major problem of warfarin toxicity is that the patient who is going to have this warfarin toxicity is going to have excessive bleeding. So this is one of the major drawback, okay, one of the major, see, again, drawback can come back, drawback also is there and positive things also are there. But one of the drawback of your enzyme inhibition is that, one of the example you can remember is that when you are going to administer this warfarin and your chloramphenicol together, this chloramphenicol which is there is going to inhibit the drug which is responsible for metabolizing the warfarin. And if warfarin does not get metabolized, it will start into systemic accumulation, and that will lead to the warfarin toxicity, and that is mainly responsible for excessive bleeding. Now we are going to discuss about the protease inhibitor, okay? This protease inhibitor, okay, now you might not be able to understand much in detail now, but this detail and this which is there, see, protease is an enzyme, okay? So there are certain drugs which are going to inhibit the protease enzyme, and this is used in your HIV treatment. So this is helping in curing HIV. Okay, this drug which is there is using as ART, as antiretroviral drug therapy or regimen. Okay, so in that regimen, you are giving this protease inhibitor, or these drugs are going to inhibit the metabolizing enzyme, that is your protease. Okay, I hope it is clear. You have understood about the enzyme inhibition and then about the enzyme induction. Now, last but not the least, we are going to talk about the last topic of your ADME or your pharmacokinetic series or pharmacokinetic series. General pharmacology is a huge series, okay, it's going to be a lengthy series. But now we're going to lastly we're going to talk about the excretion, okay, which is a very important process and very short. It won't be as lengthy as metabolism. So let's start talking about what is actually excretion and what are how the drug after getting metabolized, how is it getting excreted. Now we are going to discuss about how the drug is going to get excreted. Okay, so once the metabolism has happened, therapeutic outcome has been seen, and now this drug which is there, it has to be excreted out of the body. Okay, so there are various modes how the drug can excrete out. Okay, but majority of the drugs which are there are going to get excreted through the kidneys, Okay, now let us try to understand one by one in a very simple way. If we talk about my friend, again he is back, that is the kidney, Mr. Kidney. So what happens is, this guy is responsible for filtering out the drug, or is responsible for removing the drug outside the body. Now the drug which is there, if it is an acidic or a basic drug, okay, so then mainly I'll tell you in a very simple thing. Okay, this drug is getting excreted. Now there are mainly two mechanisms. One is here active tubular secretion, or passive drug reabsorption, or you can say passive drug transport. You can just say passive drug excretion. Okay, let's discuss about the drug excretion first. Passive drug excretion. How is it like? Passive active means based on the energy. If energy is required for removing the drug, that's called as active excretion. And if it's like, it's like passively it is getting reabsorbed, and then passive it is going to get inside the loop of Henle, then we call this as your passive drug excretion. Make it simple. See, now what is going to happen is, when we are going to take the drugs which are going to be weakly acidic drugs or weakly basic drugs, these are mainly in the unionized form. So what happens over here? The drug is going to pass the glomerular filtration. Okay, later it is going to come in the PCT, and then it's going to loop of Henle. But because it is your unionized form, what is going to happen? The reabsorption is going to happen. The drug is going to get reabsorbed. So there is slight problem with the drugs which are weakly acidic and weakly basic. Okay, because weakly, say acidic drugs, basic drugs, we can say that they are ionized form. But if we talk about weakly acidic and weakly basic, what will happen? They are in their unionized form, so they cannot be excreted. But if the pH of the urine is altered, or the pH of the urine is changed, let's see what happens. Okay, if you are taking weakly acidic drugs, it will enter the glomerular filtration, it will enter the tubular, secretion, tubular like loop of Henle. Then if the pH of the drug, is alkaline because of the sodium bicarbonates, if the pH of the drug which is there, pH of the urine which is there, it is alkaline, then what will happen? This alkaline nature of the urine is going to ionize these weakly acidic drugs. What is going to happen? Again, try to understand this. Alkaline nature of the urine because of sodium bicarbonate, the alkaline nature of the urine which is there, if the urine pH is altered, then it will cause the ionization of weakly acidic drugs, and hence it can be excreted out of the kidney, or hence it can be excreted out of the body. Similarly, see, for the weakly acidic drugs and basic drugs, these are unionized form, and we need to ionize it. Okay, so for weakly acidic drug, what am I doing? I'm making the pH of the urine slightly alkaline. And how am I making it alkaline? By adding sodium, or by alteration in the sodium bicarbonate. Similarly, for the weakly basic drugs like amphetamine or morphine, the basic drugs, weakly basic drugs, so they also cannot ionize. Okay, they are in the unionized state. So for ionizing this, what do I do? If I'm giving a patient of supplement vitamin C, okay, vitamin C is but ascorbic acid. So what will happen? This acidic medium or this acidic nature of the urine is going to ionize the basic nature of the drug, and that is why this will again, it is a convert your unionized form to the ionized, and hence it can be excreted. So simply just try to understand, when a very simple thing is that you are converting your unionized drug into your ionized drug, and once it is ionized, this kidney is going to be happy to remove this drug outside the body. Now how is it doing? If it is an acidic drug, okay, if it is an acidic drug, then they are going to alter the pH of the urine by alkaline nature, and that alkaline nature over here is nothing but your sodium carbonate or sodium bicarbonate, you can say. Okay, sodium bicarbonate ions, you can say. Okay, then later, if the drug which is there, that is going to be weakly acidic, weakly basic. If the drug is going to be weakly basic, then what is going to happen? We are going to make this slightly, the urine which is there, this is about urine, okay, urine nature, urine pH. Then the urine which is there is going to be we are going to convert, or we are going to try to make urine acidic. And how do we make urine acidic? By adding or by administering your vitamin C. Vitamin C is nothing but your ascorbic acid, and if this is the condition, then the drug will be there in the ionized state and can be easily excreted. And these both which is there is going to come under passive drug excretion. This is going to come under the passive drug excretion. Now, what is the active drug excretion? That means you're having a PCT, you're having a DCT. With irrespective of the pH and the condition of the urine, these drugs are going to actively get transported. These drugs which are there are going to get actively transported. Okay, majority of the drugs. Okay, majority of the drugs which are, like you say, acidic or basic, right? Majority of the drugs which are there are going to be excreted with the help of this active tubular secretion. I hope it is clear. I hope the concept is clear. Or if you simply have to understand that this kidney which is there is responsible, or is not the major responsible for excreting out the drugs. Okay, I hope you're understanding. Now, next, what is the role of the lungs in excretion, especially the drugs which are volatile in nature? Okay, like we talk about the anesthesias, like your halothane, isoflane, right? All these which are there, like your anesthesias, like your halothane you talk about, or you talk about the alcohol. All these volatile nature, whatever drugs which are there having volatile nature are going to be metabolized, or sorry, are going to be excreted with the help of the lungs. That's why in the, they check, right, in the police, like when they are having traffic police in the late night, they check the alcohol content when they tend to blow the air, right? So how is it checking the alcohol? Because when you're drinking alcohol, that alcohol has to exit outside the body, and because this alcohol is which type of drug? It's a volatile drug. So it will be excreted by your lungs. So when you exhale out, that's why the smell, people who are drinking, they easily can identify if anybody has drank alcohol. That's because of the smell of the alcohol. By skin also it will get your, the skin also it will get excreted. One of the major thing is by the mouth also, the lungs also. That's why when you blow it, they can detect the alcohol concentration or alcohol limits. Okay, I hope that is clear. There's nothing but the volatile nature. Now, if I talk about the fecal matter, okay, the drugs which are like purgatives. Okay, what are purgatives and laxatives? These are going to help in improving the bowel movements. Okay, these are going to help in help in the bowel movements. Like we talk about your senna. Right, one of the example is Yesena. That's also a drug, and this drug which is there is also, it's a plant, phytoconstituent or phyto drug. This is going to get excreted by your fecal matter. Now, next is your bile. Okay, next is your bile. Which type of drugs are going to be excreted through bile? One of the major drugs over here, that is your tetracycline. That is your tetracycline. So tetracycline which is there, these drugs which are there are going to be excreted with the help of the bile. Okay, that's why I told you. Remember what is the advantages of the drugs which are going to be excreted through bile. Remember prolonged action and all these things. I hope it's clear. Okay, just check it out. Check out my previous video if you're not understanding. Okay, now next is going to be skin. Some drugs are like heavy metals which are there, like your arsenic. Okay, like your arsenic metals which are there. These are going to be excreted with the help of the skin. These are going to get excreted with the help of the skin. Now, what about the drugs with the saliva? You are having a very important one. That is your potassium iodide. Potassium iodide drug is there. Okay. Then later you are having your potassium iodide is there. Then your metronidazole. Then later there are some drugs which are excreted through the milk. Okay. So see, majority of the drugs, like the drugs which are excreted through the milk, right? Like you're having your, you talk about your penicillins, you talk about your erythromycin. That's okay. Now you can give this, you can give this drugs to the women who are having, who are lactating women. Okay. But then there are some drugs which can cause, teratogenicity. You can talk about. You can say it can cause fetal stress. Okay. It can cause fetal stress, and one of the such example is your amiodarone. This amiodarone drug which is there should not be given to lactating women, because this drug which is there is going to get converted into toxic metabolite and then is going to get excreted. And the mode of excretion of this amiodarone, there is some part of the drug which is going to get excreted with the help of milk. So mainly you are having your penicillins. Okay, penicillins are there. Then you are going to have your like other drugs. Okay, penicillins are there. Then mainly amazon drug which is there, they should not be given with the lactating women. Okay, then the erythromycin, all these things can be given to lactating women, but not amedron. I hope it is clear. So mainly the drug which, how is it getting excreted? You have your majority of the part, it's your kidney, then comes your lungs, then is your fecal matter, bile, saliva, and your milk, and last but not least, skin. Okay, this was all about the pharmacokinetic matter. Okay, everything is available, notes are available in our Telegram channel. Kindly subscribe and like our channel, show your love. Next we will come upon with the new part of the pharmacology assets, that is your pharmacodynamics. Okay, it's a very huge part, very interesting part, and of course very important for your examinations too. Thank you. Taking off for today.